Great.
Yep.
So a little bit of background, full disclosure is that I am a supporter, but I am going to work really hard to try to present evidence and data and facts and not get into the debate over ethics. What I am here to do, though, is to bring a little bit different of perspective. I think most of the people who presented come from academia or come as a doctor, and so I'm going to offer you the consumer perspective. We as an organization both work to pass the law. But we also then stay in and we help patients to access the law. And so you heard some references to that earlier. I'm going to explain a little bit about our experience in that and what that means in terms of how what we advocate around. Our goal is availability, not usage, and this is really important. You've seen a lot of conversations today where people talk about minority populations, and you'll see data that shows they actually really high percentages of minorities support this. We are seeing low usage rates. So the question on the low usage rates is it a low usage because there's an access issue, or is it low usage because they're not interested in accessing that option? And it's okay if they don't want the option. They still want the option passed, and that's a really important distinction, and it's a research question. We advocate for the full range of options. So another thing that you'll hear is studying and doing reporting and stuff is okay, but we should be doing it across the range of options. This option should not be handled differently than every other end-of-life option. That's very stigmatizing for those patients who this is an option that they want. And then the last thing I'll say is that Barbara Coombs-Lee and I did a blog in Health Affairs that has all of the data around medical aid and dying, some of which was gone through today. And so if people are interested, you could just Google my name and Barbara's name and you'll see that, and that avoids. So the first question is, what do patients want? And this is what we hear most often from our supporters. In terms of the Colorado bill, just to give you a sense of just how popular this option is, it passed by a 30-point vote margin. It was the most yes votes any legislation and any ballot initiative in Colorado has ever received. It drew support in every single area within the state among every single demographic group. When you look at public opinion support, it doesn't matter how the question is asked. You know, this particular question actually uses commit suicide. You still get 68% support for the law, and you can see the increase has gone up. When you look at where the support is, this survey was done by Lifeway, which is a Christian organization that did the survey. And you see their support among every single demographic group. Hispanics are almost equal to white. It is lower among African Americans, but it's still majority support. And then in particular among the Latino population, there's really strong support, not just among people, but also among the Latino leadership. You've got people like Dolores Huertas, who see this as a civil rights liberty. You've got Jorge Ramos, who is the Univision leader who's out there advocating for this. Mauricio Achman, who is a very famous Latino telenovela star. And you've got 3 Latino organizations who've all come out and endorsed. So this is the idea that minorities do not want this option. It's definitely it's not consistent with either what the polling data shows or what the national organizations that represent those groups show. In terms of DC, and Dr. Omega Silver talked a little bit about this, but we did go and we met with every single people within every single community, and we met with the city council members within those districts. It is a majority African American city council, and every African American city council member except for one voted to support the option. This is an issue that crosses racial lines in terms of people's wanting the option. So how has medicine been responding to this? What we're seeing so far is, and you guys heard this, and you're all the doctors, so I don't need to tell you what it is. It's hard. There's no question. Like you're entering into new terrain, but I think what we're seeing is recognition from doctors that this is an option that people want. What's really important from a consumer perspective is to understand that it's not actually medical aid in dying necessarily that every single person wants. What they want is control and autonomy at the end of life, and they want to know that they are the deciders and they are able to make the decision. It's about consumer empowerment. you see that you've got increased support among doctors supporting the option. And doctors were surveyed in 3 states recently by their medical societies, and all 3 of those states had majority support among the doctors. And they then followed suit and adopted a supportive policy, or a policy that dropped their opposition in recognition of the fact that this was something that the medical society should not be opposing. So we now have 10 medical societies, of which about 8 of them happened within the last year. There was a great article that came out from John Fry, who's somewhere in the room, and Stuart Younger, that talked about the move toward engaged neutrality. And this was really a call to say, this is something that patients want, and our job as a medical society is to figure out how we bring them this option. You had the New York State Academy of Family Physicians then be the first state medical society to adopt a supportive policy, which actually said, it's actually patient abandonment for us not to help figure out how we give people who want this option in a way that is consistent with medical practice and ensures that that it's safe and effective. So that was the New York State Family Physicians. What happens with implementation? So what we see, and the reason that we are so strong and are so concerned about reporting and what that looks like, is that you get the 6-month prognosis often happens very late. So you look at the research and the data, and you've got a large majority of people who are not getting a 6-month prognosis until maybe 3 months out. So then they have this very lengthy process to go through. And if you're in a supportive system, you can get through that process in 15 days. Most people are not in a supportive system. So you go, you ask the first doctor might refer you, they might not. It takes a long time. It could take someone 3 months to get through this. The person's dying. They are, in agonizing pain, and they're just looking for the peace of mind that comes with knowing that this option's available. So there has to be a thoughtful balance between protections and access, and I think that's a research question. What is that thoughtful balance that needs to take place? In terms of research and reporting, when you look at research, as we saw over the last couple of days, there is a ton of research that's unknown on this particular medical practice. However, if you compare it to the research that's currently taking place around voluntarily stopping eating and drinking, palliative sedation, the withdrawal of medicine, hospice, there's nothing that's taking place on those medical practices. And I would actually argue that those medical practices are often more dangerous than medical aid in dying. Think of palliative sedation. There's no regulations around that. It's a doctor and a patient, and the doctor's administering the medication. With medical aid in dying, you have 15 different regulatory protections that are put in place, and it's a patient-controlled and directed. So I would say that if we're going to look at what is the kind of research that we do, we need to look at it in the totality of end-of-life not care and not single out this one medical procedure, because singling that out says to the patient that your value is somehow different and isn't okay. And that's, I don't think, what we want to do as a society. We want people to have options that are available to them. So you have intrusive, stigmatizing, and it's also a deterrent for doctors if there's too much research and caution there. So in terms of key issues that have come out over the conference, you heard some differences by state. So you heard early on Tony talk about Washington's experience and how there was a separate nonprofit organization that did a lot of work to gain access. But then what you heard in the California examples was that the medical system was actually stepping in and serving in that role. And what I would say is that that's actually what is in the best interest of the patients, is if the medical society embraces this and the medical system embraces it, because a dying person does not want to have to leave care and reestablish care at the very end of their life. There was a question that came up on the specialized doctor versus greater adoption, and I would also strongly encourage people to think about the experience of a patient to have to reestablish care. And I'm running out of time, so I'm going to go really quickly. And the distinction between disparity in the law versus wanting the option and accessing the option is another thing that came up. I think it's a research question, but we want to be sure that we're thinking about whether it's wanting or opting. In terms of research questions, why has patient demand for this option increased in recent years? What does it tell us about what patient-directed care is really all about? Which regulatory requirements are really necessary and which ones create unnecessary delays and stigma? What impact will additional data collection have on the patient's ability to access the law and the willingness to practice? Should we be researching all end-of-life options, or just, what is the impact of not passing these laws? Example, we've heard a lot of people who talked about committing suicide, the underground practice without regulations taking place, and conversations about end-of-life remaining taboo. And given the small number of people who choose to access the law and the combined 40 years of implementation experience, where are the research dollars best spent to advance end-of-life care? Thank you.